Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course with Astro APM experts for Ukraine. Help Ukraine Group, Astro International Committee, APM Clinical Education Subcommittee, Rise Contra Cancer with Sweet Care Support. We are all excited to present this sixth lecture in the course, and the topic is brain SRS. We have an amazing team of speakers, radiation oncologists and medical physicists from my home institution, Stanford Cancer Center. So their names are Dr. Scott Soltys and Dr. Greg Szalkowski. Dr. Soltys is a professor of radiation oncology at Stanford University with a courtesy appointment as a professor in neurosurgery. He serves as co-director of the Stanford Stereotactic Radiosurgery Program. He is a former program director for radiation oncology residency, former senior editor for CNS submissions at the Red Journal from 2014 to 2022. He is a radiation oncology chair on NRG Oncology BN012, investigating pre-resection radiosurgery for brain metastases, and he's also a co-chair of BN013, investigating fractionated radiosurgery for brain mets. His clinical and research interests center on developing novel treatments for brain and spine tumors, as well as functional disorders using SRS and SBRT. Dr. Soltys has authored more than 300 publications and was involved or accrued in 14 clinical trials. He is a dedicated educator and mentor. He received multiple honors and teaching awards, our Educator of the Year Award, Sarah Donaldson Mentorship Award, Henry Kaplan Memorial Prizes for teaching. And in 2022, he also became a fellow of Astro. Congratulations, Scott. It's amazing bio you have and amazing legacy you're leaving. And we are very honored to have you here as a speaker. And the second speaker is Dr. Gregory Szalkowski. He is a clinical assistant professor in the Department of Radiation Oncology at Stanford. He specializes in brain and spine treatments using CyberKnife. His clinical research efforts focus on workflow, quality improvement, leveraging artificial intelligence, machine learning to enhance treatment planning, delivery, and safety. Within the department, he serves on the Radiation Oncology Quality Council. Nationally, he is incoming member of the Astro Multidisciplinary QA Subcommittee and a guest member of APM Quality Assurance and Outcome Improvement Subcommittee. Welcome, Greg. Very nice to have you here. Thank you so much, both of you, for preparing this lecture today on brain SRS. We are really looking forward to learn from you. The podium is yours, Scott. I'll stop sharing.
Yeah, great. Thank you for that kind introduction. And I thank everyone for joining in. I know it's, 8 o'clock at night in
That's right. Yeah.
Yeah.
8 p.m.
Okay. Excellent. Yeah, thank you. And hopefully this is of interest and helpful. So this is a basic title of just brain radiosurgery. We'll cover a little bit of why to do it, and then also focus on like how to do it between some slides from Greg and from mine. So let's jump right in. And yeah, okay, so for indications for brain radiosurgery, the main ones would be brain metastases. So that's probably even here at a busy practice with a lot of non-cancer treatment. That's still probably like 70% of what we do. So we'll spend some time on the justification for doing brain radiosurgery for metastases rather than whole brain radiation. The second most common would be benign tumors. And as mentioned, Dr. Pallam will be covering some of those in the last lecture in the series. And then I'll spend just 1 or 2 minutes on functional radiosurgery because that's something completely different outside of the oncology realm that's of interest. So let's review the data-based evolution from most patients with brain metastases being treated with whole brain radiotherapy to now most patients having a database justification to treat them with radiosurgery. Yeah, and like I said, brain metastases are the #1 indication in most all radiosurgery programs. So we'll spend some time with this. So if I gave this talk decades ago, there were no data to support radiosurgery for patients with brain metastases. The standard treatment and all the trials up until then were if you had a brain metastasis, you were treated with whole brain radiotherapy or WBRT. Well, we'll touch on some of these, but that changed in 2006, and that's really the first trial, the Aoyama trial, that included a non-whole brain radiotherapy, containing arm, or a radiosurgery alone containing arm. So this is relatively new over the last less than 20 years. And then you can see where we are today, where for all of these indications, we have data that support radiosurgery alone with the omission of whole brain radiation. When you have a radiosurgery practice, when the patient fits these entry criteria for these trials. So let's look at these trials in a little bit more detail. And you don't need to know the specifics of each trial necessarily, as long as you know some of the core concepts. And when you look at all these trials with the addition of whole brain radiotherapy, so when you add whole brain radiation to either radiosurgery alone or surgery alone, whole brain radiotherapy improves brain control. So it improves the brain met that you know about, that you treated with radiosurgery or surgery. But it also improves new metastases from appearing, so distant intracranial control. So that's a general statement. Whole brain radiation decreases new brain metastases from appearing, except for melanoma. We have a trial, the Hong trial, that I'll show, where whole brain radiation does not improve the appearance of new metastases for melanoma. The other key concept is that despite whole brain radiotherapy improving control of brain metastases, this does not improve survival. So you add whole brain radiotherapy or not, the survival of the patient is the same. And also, despite decreasing the chance of new tumors appearing in the brain, whole brain radiotherapy has worse neurocognition than those new tumors appearing. So whole brain radiotherapy leads to cognitive dysfunction more so than new brain metastases appearing. Okay. So these are concepts that are seen in all of these trials. Here's kind of a summary slide of probably like an hour worth of lecture to look at each of these trials. But looking at these concepts, whole brain radiotherapy improves the rate of new metastases from appearing. So this is distant intracranial progression at 1 year. And in general, if you omit whole brain radiotherapy, the chance of a new tumor appearing is, let's say, on average, about 50%. So I tell patients that, we can do radiosurgery for your brain metastasis. The chance of a new tumor appearing sometime this year is about 50-50. So that tends to normalize it. It's not a bad occurrence or unusual for a new tumor to appear, because it happens about half the time. When you add whole brain radiotherapy, it decreases that rate. But you can see it doesn't decrease it, like doesn't omit it. It's not like going from 50% down to 10%. It's really kind of I would say, a small absolute reduction, maybe 28 percentage point decrease, but patients after whole brain radiation still have, say 25 to 30% chance of a new tumor appearing. Oh, and then I mentioned the Hong trial. So this is only in patients with melanoma, and the addition of whole brain radiotherapy did not have a significant, NS is not significant, difference in appearance of new metastases. Okay, so that's whole brain and distant intracranial control story. So whole brain radiation improves intracranial control. Does that brain control impact survival? And the answer is no. So whether you have whole brain radiotherapy or not, survival is, as you can see, and all of these are not significant, or the only one that is significant is the one that does not have whole brain radiotherapy. There are reasons for this in the Chang trial that we don't need to get into, but just say intracranial control does not correlate with overall survival. Well, if it doesn't correlate with overall survival, what about the chance of having neurologic survival? What is the chance of dying of brain metastases or with active brain metastases? And that's a little bit more unknown. We have trials to kind of gone back and forth over the years and decades where maybe whole brain radiation improves neurologic survival, then it doesn't, then it does, and then the last two trials have been no. So I just leave it at it's unknown if that impacts neurologic survival. So since multiple early trials showed that the addition of whole brain radiotherapy does not improve survival, probably doesn't even improve neurologic survival, then what does it do? What should our endpoints be to study if there's a benefit to it? So then trials started to become focused on neurocognition and patient-reported outcomes. So ask the patient how they're feeling and have various questionnaires and see what happens. And during the early time of these trials, there were data that people that do have new tumors that appear, that can lead to cognitive dysfunction. And then we knew that whole brain radiation can lead to cognitive dysfunction. And there were debates about which is worse, like new brain tumors appearing or whole brain radiation, which decreases new tumors from appearing. Well, we now know that intracranial progression is actually better for thinking and cognition than whole brain radiation. Here are the key trials over the years, either adding whole brain radiation or looking at prophylactic cranial irradiation for non-small cell lung cancer. And I kept the summary almost identical. So again, despite improvement with an intracranial control with whole brain radiotherapy, the arm with whole brain radiation had worse neurocognition. Okay. So going through this box over the years, that brings us to this area. All of these trials I just showed are only for patients with 1 to 3 or 1 to 4 metastases. So we didn't have data on more than 4 metastases. So what do we now have for more than 4? And this gets into the definition of what is a limited number of brain metastases. Astro guidelines, for example, said long ago, like for a limited number of metastases, do radiosurgery alone and save whole brain radiotherapy for when it is no longer limited and there's more than that. Well, the definition of limited is changing. Basically, the limited is becoming a greater and greater number. This gets into the controversy or previous controversy. What's more important for the patient? Is it the number of brain metastases or the size of metastases? So you may think that, for example, we can control a brain metastasis, say 90% of the time. So if you just do, the math or the statistics, more tumors should be worse because you're more likely to have one of these grow, 10% of the time than 2 of these. Well, for survival, it's actually the volume of tumor that is more important or associated with survival than the number. So this patient with 2 metastases has a worse survival than the patient with 10. And that's seen in many, many papers over many years. Number of metastases may correlate with survival, but when you control for volume, the more number, the greater the volume usually. But when you independently control for it, the number of metastases is not significant. So you don't need to go by number by limiting the use of radiosurgery. And we finally have some prospective data for this too. So this is the paper that provided prospective evidence of radiosurgery alone for up to 10 metastases. So this is not a trial. This is a prospective registry in Japan. And they looked at survival and found that, sure, if you have one tumor, survival is better. But the survival for 5 to 10 was non-inferior to those with 2 to 4 tumors. So if you justify doing radiosurgery for 2 tumors, you can justify it for 10 tumors if survival is your endpoint. So that I'll take a break and ask the first question. How do we do this? Okay, that's how we do it. Thanks.
Yeah, I will control it. So you can read the question. It would be nice because it's translated.
Yeah, okay. So question number 1, for patients with brain metastases, the addition of whole brain radiotherapy leads to what? A, increased overall survival, B, increased neurocognition, C, increased intracranial control, or D, improved patient-reported outcomes.
And I'll wait until approximately 80% answers, and then I'll stop the poll and share. You can comment on the results. So we have around 70% answering, waiting for more. Okay, I'm ending the poll, sharing results. So majority of you answered C. So 53% answered increased intracranial control.
Yeah, so that's correct. I didn't show the trials of pure patient-reported outcomes, but that correlates with neurocognition. So C is the correct answer. Whole brain radiotherapy versus not. Survival is not changed. When you add whole brain radiotherapy, neurocognition is worse, and patient-reported outcomes are also worse.
Worse.
So all we have is radiation, whole brain radiation increases intracranial control. How do I change? Okay, so I showed the data for 1 to 10 metastases, that's Yamamoto. So going through these kind of indications, now up to just recently, if you had surgery for a brain metastasis, then the standard of care was to do whole brain radiation. That's one of those early Patchell trials from several decades ago. But that has changed. So that changed, I guess not too recently, in 2017, but this is the NCCTG N107C trial. Patients with a resection cavity, or patients who had resection of a brain metastasis were randomized to whole brain radiation. That's the standard of care at the time, versus radiosurgery just to that resection cavity. Okay. The endpoint was overall survival, but we knew that that was going to be unchanged from all the past trials. So it's really a cognitive endpoint. And in this trial, we see all the things we just talked about. So when you add whole brain radiotherapy versus not, tumor control at that site is improved. Okay, we know that. Distant intracranial control is better. So the overall progression in the brain is double. You have better intracranial tumor control with the addition of whole brain radiation. But despite that doubling of brain control, survival is the same and cognition is worse in the whole brain radiotherapy arm. So the authors concluded, post-resection radiosurgery should be considered one of the standards of care. And, it's the winning arm of a randomized trial. So you could say it is the standard of care if you have, radiosurgery capabilities. So that checks this box in favor, following surgical resection. Okay. So that's what we know. Let's spend some time on some areas that we don't know the answer. So these are some unanswered questions in radiosurgery for brain metastases. And one question is, have we optimized the sequencing? In someone that needs surgical resection of a tumor, usually we take it out and then do radiosurgery to the cavity, like I just showed. But is that the best for the patient? And maybe not. So with that Paul Brown trial we just looked at, radiosurgery to the post-resection cavity is the new standard of care. But with that new standard of care, we are seeing a completely new pattern of progression in the brain that we have not previously seen when we were doing whole brain radiation. So here's an example. And this pattern of progression is called nodular meningeal disease. This is tumor on the meninges. So here's a patient, has a large tumor. It's removed. We do radiosurgery to that resection cavity. The cavity is controlled, but months later, they get this tumor that grows on the meninges. This is the pachymeninges in this case. Around the corner to the left, around the corner to the right. And this entity, I think, is under-recognized and misdiagnosed. So here's a patient, had cavity radiosurgery. They show up in your clinic 6 months later, and they get a new MRI, and it shows this. And at first, it just looks like a new left cerebellar brain metastasis, which is not unusual. It happens 50% of the time, like we mentioned. But if you really look at it, you realize, oh, this is not tumor in the brain. This is tumor kind of on the brain, or it's actually on the dural surface. So this is CSF spread, so cerebrospinal fluid spread of tumor cells at the time of surgery. They float around and then they land on the dura and then start to grow. So you can see it here. You can see it on the dura up above. So the nodular meningeal disease seen with post-resection cavity radiosurgery, this is different than tumor cells floating in the CSF that causes classical leptomeningeal disease. So classical LMD, we see that frequently. That's tumor on the peel surface. It's described as like a sugar coating over the surface of the brain. Nodular meningeal disease, like here's a resection cavity in blue that's controlled because we treated it with radiation. But around the corner, you get these dural implants. It can occur underneath the tentorium. It can occur above the tentorium. So this is iatrogenic, meaning that physicians cause this. This is a result of our new treatment paradigm. And the reason why I say that is this paper. So nodular meningeal disease is an iatrogenic result or complication of doing surgery followed by radiosurgery. So here's a good paper, 318 patients who had resection followed by radiosurgery compared to 800 that did not have surgery. They just had radiation alone. And you can see this entity of nodular meningeal disease occurs only in the post-resection setting. Like no patient gets it if you don't have surgery. Contrast that to classical LMD, which is biologic. It's going to happen 10% of the time in this case, independent of what you do. Okay. Here's some other examples. It can occur in the dura in the brain. This is the pachymeninges. It can occur in the thecal sac, the pachymeninges of the spine. It can also occur on the leptomeninges, or the peel surface, the covering of the brain rather than the covering of the bone, in the brain or in the pia of the spinal cord. Right? So what's the problem with this? Well, these women who come back after surgery and radiation to the resection cavity, they both look like they have a new left cerebellar metastasis, but this woman in the left screen has a 70% chance of dying from brain metastases ultimately. And that's because she's the one with nodular meningeal disease. Okay. The woman on the right just has a new brain met. Happens 50% of the time. And that does not impact survival. So if dissemination of tumor cells at the time of surgery, which then floats, becomes nodular meningeal disease and can lead to neurologic death, if that's the problem, then why don't we just flip the order of that? Do radiosurgery first and then resect the tumor. And if the tumor cells are spilled at the time of surgery, it doesn't matter because they've already been treated and they don't grow. So that's the concept behind the current trial that's being run in through Energy Oncology. So metastasis is resected, and they either get radiation before or radiation after. So pretty simple trial. This will be closed in a few months. So that's one unanswered question in radiosurgery. The other question is, so we provided data for up to 10 metastases. What about 11 or more metastases? And I used to say we had no data to support that in a prospective manner. So the standard was whole brain radiotherapy. But we now have data. This is one trial that's still open. The data we have is not from this trial, but hopefully this will accrue and provide some support looking at radiosurgery alone versus hippocampal avoidant whole brain radiotherapy. It had trouble accruing. It was originally slated for, or open for 5 to 15 metastases, but they changed it to unlimited metastases can be treated with radiosurgery as long as the total brain met volume is less than 30 cc's. Okay. So we'll see what this shows, hopefully. But in the meantime, we have this trial that was reported just a couple months ago at ASCO meeting. So this is 5 to 20 brain metastases were randomized to hippocampal avoidant whole brain radiotherapy versus radiosurgery. And the endpoint was patient-reported outcome, a metric of like what symptoms do you have and how much do those symptoms interfere with your life. And the answer is radiosurgery arm had better patient-reported symptom severity and interference. So they conclude that for patients with 5 to 20 brain mets, they have fewer symptoms and less interference with radiosurgery than with whole brain radiotherapy. Didn't affect survival, and they said that this is the standard of care in this patient population. Also note, this wasn't just like 5 or 6 brain metastases. The average was 14 per patient. So these are good data to support that. Okay, so that kind of was 30 years of maybe 10 trials or so on all in a few slides. One of the last unanswered questions is, and we'll get into dosing and how to do this, but should you do single fraction radiosurgery? Like this is the historic standard with frame-based techniques, or is there a benefit to fractionation? Overall, the answer is we don't know if there's a benefit to fractionation, but there are trials exploring that. So why would you maybe want to fractionate? Well, here are older data, but this is all single fraction radiosurgery. And as the tumor gets much above 2 centimeters in size, you can see the local control drops, usually down into the 50 or 40, 50% range. So single fraction radiosurgery is good for tumors up to about 2 or 2.5 centimeters. And then most of us, when we do fractionate, say over 3 days, we use this paper to justify it, but these are retrospective data, but they're still pretty good and helpful. These are 289 patients with metastases greater than 2 centimeters, and they looked at 1 fraction versus 3 fractions. The three fraction arm had quite a bit larger PTVs. It's like 50% larger. But despite that larger PTV, we saw what we think could be the benefits of fractionation in that they had better local control and then better radiation necrosis at 1 year. So these are retrospective data. I'll come back to this. We need prospective data. This is the current cavity trial in the United States. I think it actually just closed recently. So resected brain metastasis, either get 1 fraction versus 3 to 5 fraction radiosurgery to the resection cavity. So we'll know in the post-resection setting. And then this is the current trial for intact metastases. So again, intact metastases greater than 1 centimeter are randomized to 1 versus 3 to 5 fractions. So we hope to have prospective proof that fractionation may be beneficial, but we don't know that. If you do have a large met, I'll go back to this slide. Another option is, when we do fractionation at Stanford, we usually do it just like 3 days in a row. But there are groups that are looking at fractionation over months. So here's a example where you have a large met, you give it kind of too low of a dose expected to control the tumor, but then you just wait a month until it shrinks, and then you have a smaller target, and then you give it another fraction. So fractionate it over months. And they report, that this is a good option. Okay. Yeah, so let's go to question number 2. So for which indication do we not have prospective data supporting radiosurgery alone with the admission of whole brain radiotherapy? So 1 to 4, 1 to 10, 5 to 20, more than 20. You're not supposed to ask a negative question, but I just think this is reasonable.
Yeah, that's reasonable. I think people will answer correctly because you made it so logical in tabular format. I think people get it.
Yeah.
So we have around 70% answered. So waiting for a little bit more answers. Okay, great. I'm ending the poll, sharing results. So majority of you answered D, 21 plus metastases.
Yeah. So we have the IOIZER trial that goes up to 20. I guess we could have prospective trial if the energy trial completes accrual, because that's unlimited. So there would be people with more than 20 on that arm, I think. So. Okay. So that was why to do radiosurgery, how to support the use of it in patients with brain metastases. Let's look at how to do it. And some tips and techniques. Greg will go into this more in the physics portion of the talk too, but in general, brain radiosurgery for metastases requires an MRI scan. Usually we do that within like 0 to 7 days of the actual treatment. So oftentimes we'll get a new MRI on the day of planning when they get their CT scan and their mask. The main requirement is it needs to be a volumetric 3D scan, and for example, wording that we put into the energy trials is this. It's just a post-gadolinium contrast T1 weighted 3D spoil gradient scan. So it just depends on the brand of your MRI scanner, but all of these are reasonable. They're like MP Rage, FSPGR, Bravo, TFE. They're all kind of flavors of the same thing. And it needs to be thin slices. Usually they're like 1 millimeter. And for example, in the trial we required has to be less than 1.5 millimeters. We get a CT scan for treatment planning, somewhere around 1 millimeter slices also, and you fuse the two together. At Stanford, we do typically add CT contrast. So the CT contrast is not necessarily to help see, 5 millimeter brain mets. It's more for me to see the blood vessels on the CT, and then that helps with the fusion of the MRI. So you can fuse blood vessels to blood vessels. So I do find CT contrast helpful mainly for the fusion. But that said, like occasionally we have an MRI that's like 2 or 3 days old, and then we get a CT, and then we realize like, oh, that brain metastasis has bled and it's much bigger, or there's rapid growth, or we do occasionally see things through the CT contrast that lead to changes in the treatment. Okay. Once you have the MRI and CT fused, you need to draw your volume. And one thing that I do is use a very narrow window on the MRI, and I'll show you what that is. It leads to more efficient contouring for the doctor, and it's also more reproducible. And what that looks like is like here's an MRI, like this is good enough to know, like when you're in clinic and you just need to tell the patient they have a brain metastasis, this is fine. But if you wanted to try to draw volumes on this, like I don't know, do you contour the dark gray or the little bit darker gray or the light gray? So that's not that reproducible. So I usually narrow it really, window it really narrowly, and then you're not contouring gray versus gray, you're just contouring black versus white. So I think like if we all drew a contour on this, it would all be pretty similar, whereas there would be quite a bit of variability in here. I didn't grab this little piece because this is a blood vessel coming off. Okay, so that's your contour. What about dose? So we do have data for this. So this is R2G 9005. So this is, a trial started in 1990. So that these are now old data. But in this trial, 156 patients, all of whom had had prior radiotherapy. So they either had, for example, like 60 gray for GBM or a lower grade glioma, or 30 gray and 10 for brain metastases. Their tumors grew back, and then they were treated with radiosurgery. And the goal of this trial was to find the maximum tolerated dose of escalating doses. So a common question is, someone had whole brain and then their tumors come back and we want to do radiosurgery. Do I need to account for that whole brain radiotherapy dose? And the answer is no, because our radiosurgery dosing is based on 100% of people that have had prior radiation. Okay. So the results of this trial, I won't go into too much, but they bend tumor sizes into 0 to 2, 2 to 3, 3 to 4 centimeters. The doses were escalated, and then they looked at acute and chronic toxicity. And then the final answer was for metastases up to 2 centimeters, the recommended dose was 24 gray, 2 to 3 was 18, and 3 to 4 is 15. Okay, so 24, 18, 15 for 2, 3, and 4. This is all single fraction. So we'll go right from here to the next question. So again, 24, 18, 15 for 0 to 2, 2 to 3, 3 to 4. So question 3, so per this study, the recommended dose of radiosurgery for a tumor maximum size of 2.3 centimeters is 24, 18, 15, or 27 and 3.
You're testing memory.
Yeah, no, I'll go back. It's an open book question. So this was 2.3 maximum, so
Mhm.
fits into this too.
Okay, basically giving out the answer.
Well,
Ending the poll and sharing results. So majority answered 18 in one fraction. Good job.
okay. So that's dosing per RTOG 9005. That's reasonable. What do I usually do? Well, I kind of consider like 24 to 18 is a pretty big drop. If it's 1.9 centimeters versus 2.1, like that's a big jump. So I usually kind of smooth out that gradient, and I do use like 22s and 20s. So something like this. Somewhere around 2 centimeters, like I mentioned, I start to be concerned about local control, and possibly maybe fractionation helps that. So I do, above 2 centimeters, usually do like 27 and 3. For some other notes, now that we're in the era of treating up to 20 brain metastases, usually when I'm treating that many, I'm not doing 24s. Usually I'm like 2 gray less or 2 to 4 gray less. So I usually do like 22 gray for all these little spots in patients. So I decrease the dose. If treating colorectal metastases, there are data that those have worse local control. That's like the only histology that I increase dose for. So I will not dose reduce for those. So even if it's a larger met, I'll do a full 24 and 1, or if I fractionate, it's at doses higher than this 27 and 3. Okay. They're not great data for that, but that's their data to support the thought of dose escalation. Right? That this is just our practice. We do like 24s and 22s. Many radiosurgery centers, they never go above 20 gray for any metastasis, and that's just their practice. So like when we write trials, we have to say, kind of 20 to 24 gray for small mets, depending on your institutional, practice. Okay. Yeah, okay, here. Question 4, a little bit longer one. So a patient has radiosurgery for 4 brain metastases. The dosing was per RTOG 9005, like we said. And then months later, they come back and they have multiple new brain metastases, and you decide you want to do whole brain radiotherapy, 30 gray and 10 fractions. So in consideration of the past radiosurgery dose that you gave, you are planning the whole brain radiation, and what should you do? Do you need to lower the total whole brain radiation dose? So don't do 30 and 10. Do you do IMRT and make little holes in the dose in the areas of the prior radiosurgery? Or do you use 3D blocking and just make holes in the area of the past radiosurgery? Or you do nothing different with the whole brain plan?
Okay. So 82% answered. I'm ending the poll, sharing results. So majority said B, do IMRT to make lower dose holes.
Yeah. So I I usually do nothing different in the whole brain plan, because again, the dosing for R2G 9005 is in people that all of whom have had prior either whole brain radiation or 60 ray radiotherapy. So our maximum tolerated dose is based on re-irradiation, essentially. So,
Would that matter the time from prior radiation?
Yeah, I mean, so yeah, this is a median of 17 months later.
Uh-huh.
A lot of this median are lower grade gliomas. That's kind of pulling it. Like the whole
Right.
brain met patients had a much shorter median, obviously. No, I don't change it. The only area where I do pay attention if they've had prior radiosurgery to multiple courses would be like chiasm or brainstem. Then yeah, if you've kind of used up your chiasm tolerance, then I would be cautious with whole brain. So I guess that's part of the planning. I don't know if I have a slide on that, but when treating, say, 20 brain metastases with radiosurgery, we turn off the chiasm and optic nerves so that each plan like just gives something less than a gray to the chiasm. So you don't want to give 5 plans, each giving like 3 or 4 gray to the chiasm, and then need to do whole brain a few months later.
Makes sense. Thank you.
Um,
Do you mind dismissing your reminder so it's not in a slide?
oh yeah, thanks.
Perfect. Yeah.
Okay, so that's volume, that's dose. What about other techniques? Well, Greg will spend some time on this, but you need to pick an isodose line to which to prescribe that dose. And somewhat in general, the lower the isodose line up to a certain point, the steeper, the better the gradient outside of the target. So somewhat arbitrarily, for example, with Gamma Knife, the 50% isodose line is the line you prescribe to. So if you're giving 20 gray, you prescribe it to the 50% isodose line, which means the maximum dose in that target is twice that 20 gray. So there may be 40 gray Dmax in that target. Historically, like for isocentric LINAC, the steepest gradient was thought to be around 80. CyberKnife's a little bit different because it's not isocentric, but still, in general, kind of the lower, the better. Okay. So now that you're treating tumor, we talked about efficacy. Of course, any efficacy is balanced by toxicity, and the main complication or toxicity of brain metastases is radiation necrosis, or a lot of papers are written as adverse radiation effect. So adverse radiation effect is the imaging correlate of radiation necrosis, which is necrosis is really a histologic diagnosis. Like, so it's just semantics, but just know what we're talking about. So what are the risks of radiation necrosis or adverse radiation effect? Obviously, it's volume dependent. So the larger the size of the tumor, the greater the risk of adverse radiation effect. Here's a good paper from UCSF, to just our neighbor to the north. Over 2,000 metastases, and you can see the outcomes. But in general, for these small metastases, the risk is just, less than 1%, 1%. It's not until you get to a little bit larger tumors, up to 1.5 cc's, where you start to see double-digit ARE. So this is the risk based upon volume. For other dose constraints, sorry, I didn't mean to highlight the yellow, but what can you use in developing your SBRT practice? Well, of course, there's Bob Timmerman's tables. I think these are all reasonable. They're not necessarily data-based, because we don't have a data for a lot of these. And then conversely, we do have data to support going above some of these. So like we routinely will give in the right situation, give optic nerve 12 gray or more. Okay. So you can use those. Of course, in 2021, there are the high-tech issue in the Red Journal to complement the Quantech issue years ago. So this is a whole issue specific to SBRT or radiosurgery either dose constraints for normal organs or for tumor control probability. And for CNS, these are the 6 papers that are there. So if we look at normal tissue complication probability, so side effects from brain metastases, you can use these. This is the volume of brain getting 12 or 14 gray to certain sizes. And for example, a V14 of 10 cc's would be somewhere between, depending on the grade of toxicity, like 1% bad toxicity, 6% of any sort of toxicity. Okay. So that's necrosis. This is tumor control. So modeling all this, you can see the various, you can pick a dose and just see what the expected modeled local control may be. Okay. So these papers came out in 2021, and then some of us heard like a year or two later that physicians were asking like their physicists, like, hey, let's treat this brain met, but give me a dose to give the brain met such that toxicity is less than 1%. And we got alarmed because, for example, that may be like 14 gray to a brain metastasis. Sure, that's going to be safe and not cause necrosis. But if you give 14 gray in one fraction, the tumor control rate is going to be bad, like 40%. So we had to, had this editorial say, look, to treat a brain metastasis and expect durable tumor control, radiation necrosis is necessary. So these tables that I just showed you in high tech are not thresholds beyond which you should not go. It's just a risk, and risk of radiation necrosis is needed. Like if you see no radiation necrosis, you're probably not controlling tumors well or not giving a high enough dose. And it just gets into your standard, sigmoid shaped curves of even at optimal tumor control, you have to accept some small risk of radiation necrosis. Okay. So since radiation necrosis is a necessary risk, how do we treat it? Yeah, I won't read this out, but the gist of this is neurosurgeons often do 4 milligrams every 6 hours. Neuro-oncologists say that doesn't make sense because the half-life of dexamethasone is days. So just do it once or twice per day. Okay. So oftentimes, and still you see this coming out of neurosurgery at Stanford, like the patients will get discharged on 4 milligrams every 6 hours. So they're setting their alarm at 2 at night to take a medicine that keeps them awake at night, and then that just leads to a bad cycle of no sleep. So that's timing. As far as dose, 4Q6 is usually way too much. Like, sure, you can do 16 milligrams total if they're really severe symptoms and like herniating. But in general, if patients have mild symptoms, just I have headache, I have a little bit of weakness, maybe some nausea, then something 4 to 8 milligrams is the dose to give. And these neurosurgery guidelines were endorsed by ASCO and SNO. So they just said, more or less, we agree with this. So what do I do? Well, if I ever do give steroids, I do it once or twice a day. If I'm doing it twice a day, BID, I dose it in the morning, say like 8 a.m., and then do the second dose not at 8 p.m. right before they go to sleep, but dose it in the afternoon. So then they can sleep a little bit better. I do twice a day, but not every 12 hours. And if they just have edema on their MRI, you don't need to treat that if they're not having symptoms. We're treating their symptoms, not treating an MRI scan, right? But if they have mild headaches, then just like 2 twice a day. something a little bit more, then up to 8 milligrams total per day. And then only in the like really severe setting do I go up to these higher doses. So I will not go, well, I'll spend one minute on this. So that's, the bread and butter of what we do. There's some other interesting things you can do with a busy radiosurgery practice. People with trigeminal neuralgia, you can give 75 gray times 1. Pain goes away close to 90% of the time, and it's pretty durable. Some other interesting things, essential tremor is an indication, accepted indication for radiosurgery. There's a man that has tremor on both sides, like can't hold the pen to the paper. And then you can give like 130 gray times 1. You end up with a little hole in the tremor part of the brain. And then you can see like before he could not hold the pen still, and then now he can trace around this. So this is a highly rewarding indication for radiosurgery. So people can now drink, they can eat, they can hold their grandchildren, things like that. Okay, so my last question, number 5. Following radiosurgery, a patient has symptomatic necrosis, but their symptoms are pretty mild. They just say, yeah, I have a headache. It's like 3 out of 10. It does impair my daily activities, so I do want some medicine, but nothing else. So what's an appropriate or perhaps most appropriate dexamethasone dose?
Scott, how many patients have you treated with a tremor? Just curious.
We have a growing practice on that, not too much. The larger group of patients at Stanford get MR guided focus ultrasound because there's a whole program for that. There's a New England journal for that. But some people are not candidates for ultrasound, so they come to us. But we've treated just a little bit over 10, I think.
That's great.
Other practices, they don't have ultrasound and they're treating people with tremor like all the time. It's nothing experimental. That's a standard treatment.
That's awesome.
Okay, so for this,
Okay, so ending the poll, and the results are split actually between the last two, C and D.
yeah, I think yeah, I usually just dose the second one in.
Avoid the evening.
Yeah, so that way they don't have like kind of a burst of steroids right when they're trying to go to sleep. And I think people do sleep better on this. So yeah, I'll skip this and give it to Greg. So brain radiosurgery is the standard of care now for most patients with brain metastases. There are some unanswered questions such as the role for fractionation, but we're trying to get the answer to that. It is a standard of care for what Dr. Pallam will talk about, and I just mentioned tremor. And then there are new indications for radiosurgery that I didn't touch on too much. Here are some of the citations for the trials that support radiosurgery for brain mets. And yeah, I welcome any questions. I guess we'll do questions at the end.
Yeah. Do you need to leave?
No, I can.
No, you can stay. We can do questions at the end then. But I would like you to, if you don't mind, showing some slides that you, what the work that you are doing. That's really cool. I think people would like to see it.
Oh, the pituitary trial?
Yes. I think it's very interesting.
Yeah, I do too. We'll see. It's not indicated, not paid for by insurance. So we have a trial. We'll just need to see if we can do it. So this is for people who have pain from cancer that is refractory to everything. They're just in pain. And back in the 50s, 60s, 70s, like surgeons would go in and just remove the pituitary and the pain goes away immediately. Now, obviously, they become hypopituitary and that's a problem. So there are a body of data for doing radiosurgery to the pituitary gland. So this is 150 gray, and then the pain before and after is improved. There's enough interest that there are, review articles on this, small numbers, but again, pain results with high doses. So we are developing a trial where we need a nice acronym, but maybe this may work. But basically,
Inspire is good.
I know we had like sharp and things that were not as friendly as sounding, but this is either immediate or delayed radiosurgery to the pituitary gland to help with pain. So.
That's awesome. That's very inspiring. Thank you for showing that.
Yeah, thank you.
Thank you so much, Scott, for such a nice didactic lecture. I like how you're very logical, and then I think everybody learned a lot from what you've shown. So that's quite impressive and amazing. Thank you, Scott. And our next speaker is Greg Szalkowski. Greg, do you mind sharing the slides?
Yeah, you can see everything, right? Yeah, so thank you, Scott.
I don't see it yet. Okay, yeah,
Oh,
great.
do you see it? Okay, good. Yeah, so Scott talked about how to indications, so I'll talk about the more implementation portion of SRS-RT. So to start, I'll talk about different techniques of immobilization. So of course, the kind of original version of mobilization for SRS treatments was the stereotactic frame. So again, this is the easiest way to assure you have very minimal, if not no, patient motion by rigidly fixing this frame to the patient's skull, and then you can mechanically attach that frame to your treatment couch. The other advantage of doing this sort of technique is you have the frame as a frame of reference in case you need that for helping with like your treatment targeting or things. The other issues with this is that, of course, it requires a surgical procedure in order to attach and remove this frame. It also means that you need to do both your imaging, planning, and treatment while the frame is attached to the patient. So this can be a lot of stress to the care team. Typically, it means that there's like nonstop work for about 6 hours while you simulate, try to contour and plan everything. And again, having this frame attached is not necessarily pleasant for the patients. The one time that I've shadowed one of these treatments, the patient actually wasn't able to tolerate it long enough for us to actually make it to the treatment. And of course, you can only perform this with single fraction treatments. You're not able to kind of come back and do a fractionated treatment if you're using a stereotactic frame. So typically, a lot of machines are moving more towards doing frameless radiosurgery. However, if you're doing frameless radiosurgery, using a standard thermoplastic mask typically does not give you enough immobilization. Like the typical mask you'd use that just covers over the face is still going to allow maybe 2 to 3 millimeters of motion, especially with like head tilt and things like that. So there are SRS specific types of masks, like these clamshell designs. These typically come in 2 different formats. There's the open face design that's shown here. So this is typically used if you have some sort of surface guidance to do intrafraction tracking of the patient. Or you could have a closed face mask design. It doesn't allow for this, but it does immobilize the patient slightly better, meaning that if you don't have that surface guidance, it may be better to go with the full face mask rather than an open face design. We don't typically do it here, but you can use a bite block to help, again, further minimize that motion, especially, again, that head tilt. We have found that patients don't necessarily tolerate it very well, so it may not work for all cases. And again, depending on, as you're implementing a new mask, we'd recommend doing more intrafraction imaging to kind of monitor how much motion you're getting with the immobilization technique that you've chosen. and then adjust your PTV margins as necessary to account for that. As Scott mentioned, we both need a high-resolution MR and high-resolution CT. We always will do under 1 millimeter for all of our voxel dimensions, and that's typically needed for the targeting accuracy that we need. And then again, we'll fuse in a MR, typically the series that Scott mentioned. An important thing to note is you do want to make, if you're doing your targeting based on MR, you want to make sure that your MR machine is being QA'd for geometric distortion. MRs can have distortion based on inhomogeneities in the magnetic field. Typically near the center of the image, you're not going to see very much distortion. But if you move out from that center, more towards the edge of the brain or more towards like the skull base, you could start seeing clinically relevant distortions if they're not corrected for on the machine itself. In some machines, specifically like gamma knife machines, they do MR simulation. And then the way they can get around the MR distortion is, since they image the stereotactic frame, they can use the frame itself to help correct for any potential geometric issues with the MR itself. So we'll roll into the first question. So again, on a C-arm, so standard linear accelerator without surface guidance, what would be the most appropriate immobilization for a 3-fraction SRT treatment?
Okay, so we have majority answering the poll, ending the poll, sharing results. So majority 50% answered C, clamshell rigid nose.
Yeah, so that's the what we should go with. So again, stereotactic frame we can't do for multifraction treatments. And then again, standard thermoplastic mask is not going to give us quite enough immobilization that we want for this style of treatment. Open face, technically you could use, but again, wouldn't necessarily give you quite as much immobilization as a standard rigid mask. But so moving on from simulation, once you've had your patient mobilized and scanned, so PTV margin. So this will depend on your targeting accuracy. For dedicated SRS machines, such as like the CyberKnife or the Gamma Knife, where we have very good interfraction motion management, we'll typically use a 0 millimeter PTV margin. There are some centers that use 0 millimeters on LINAC SRS, but more commonly, you would use a 1 to 2 millimeter margin for brain targets. Here at Stanford, we typically will do 1 millimeter on LINAC SRS. The downside of this is that means for very small targets, you do irradiate a lot of normal tissue relative to what you're radiating as the target itself. And also for LINAC SRS, we generally won't treat, we don't treat targets if the target plus the expansion is less than 6 millimeters. So any target that we're treating under 5 millimeters will basically increase the PTV margin such that the PTV that we're optimizing to and treating is 6 millimeters. For other centers, some will again make that minimum size slightly larger than us to 7 to 8 millimeters. But so for the plan design itself, as Scott mentioned, like conformality is and getting a sharp gradient is very important for our treatments. So again, the primary thing we'll use for on the optimization side is using ring structures or dose fall-off optimization functions in order to push this down. And a few slides I'll talk about more specifically the rings that we would use for LINAC or like our CyberKnife treatment planning. One of the primary ways that you can get this sharper fall off is to increase the number of beam directions that you're coming in from. So again, for a dedicated SRS machine like the CyberKnife or the Gamma Knife, you're coming in from, say, up to 100 different potential angles, which is helpful. On LINAC, we typically will do this by doing non-coplanar arcs. So you can see here, there's the standard arc that you could use, and then as we add on different couch kicks that give us different angles to come in for treatment. The downside for, again, increasing the number of arcs is you have increased issues with potentially entering through missing tissue or exiting through tissue that you don't want to. So for example, like we would typically not do this full apex arc. That means that you have a lot of dose exiting directly through the body. Particularly for patients who have a long expected survival after the treatment, we don't really want to drop all of this dose into the body and do that, have that increased secondary cancer risk. And again, for the dose calculation itself, we will also need a high resolution dose calculation because of these high gradients in order to have a accurate representation of the dose that we're actually delivering for the patient. Again, so these are specifically like the different arc angles, or for different numbers of arcs, the different treatment angles and couch angles that you could use for delivery. Again, this is from a nice paper by, I believe, University of Alabama, who does a lot of LINAC-based stereotactic radiosurgery, and they have a lot of nice guidance documents on this. So again, one of the primary things that we do for blocking, especially when we're coming in from these additional beam angles, for the optics and the lenses, we will avoid entry and exit if feasible. Again, if we have a target that's directly next to one of the optic nerves, they're not going to be able to be this restrictive in our beam entry and exit. But what we do want to do is, as Scott mentioned, minimize the dose that we're delivering in any individual plan in case we need to come back for either another round of SRS or if we need to move to whole brain. For the oral cavity, we typically will avoid entrance through this for a couple of different reasons. One is that we have some density uncertainty. A lot of patients will have dental fillings, which will cause CT artifacts, and we don't want to deal with that uncertainty in our dose calculation. Even our fairly rigid masks still allow for some lower jaw movement. So having the mandible move in or out of the field can cause, again, some more change in the tissue that the beam has to come through. Especially for LINAC SRS, this is not typically an issue. And then for like CyberKnife or Gamma Knife, you typically don't need those angles anyway. Again, we're primarily talking about brain metastases, but again, for benign disease that you might treat with SRS, we do try to avoid exiting through the neck, basically delivering body dose to the body. The exception for this is typically for trigeminal neuralgia or those other functional cases. We will still allow exit through the body just because we want those additional beam angles to give us a more conformal plan and a sharper drop off. In terms of ring structures, these are again the recommendations that I believe we used here at Stanford as well for a LINAC-based SRS. So typically we'll have a 2 millimeter, a 5 millimeter, and a 15 millimeter ring. That really helps us push on the conformality index, the gradient index, and then the general dose fall off, which we'll go over again those terms a bit later. CyberKnife for our treatment planning, we do something similar, again, using these style of rings to help push down our conformality. Another option you can use if, for instance, you don't necessarily have a high resolution multi-leaf collimator, is to use a stereotactic cone. So these have the advantage of being basically a fixed, typically small size beam. They're well collimated, meaning you have very little penumbra outside of, or less penumbra than you might have with an MLC plan outside of the field. And since you don't have the uncertainty of MLC leaf positioning, you can be a bit more confident in the consistency of, say, your output factor and your field edges than you may be with a MLC. Again, the downsides of this, you are only able to aim at a single point, meaning that these are not typically useful if you're doing a multi-target treatment, which I'll talk about in the next slides. And again, you have a fixed, basically spherical dose distribution if you're doing an arc, meaning your CI may be worse even if your gradient index, your lower dose fall off is better. The other issue is because you're attaching a aftermarket thing to your machine, you may have more of an offset between your radiation offset ISO center and your mechanical ISO center than you may have if you're using the native collimation in your machine itself. Another issue with these is you have to be very sure that your collimation on the machine itself is collimating the field down small enough that the rest of the field is being caught by the cone. So for example, if you accidentally left your collimator out at like a 20 by 20 field, the edge of this cone is not meant to attenuate beams, so then you'd be delivering an SRS dose to basically the whole brain. There was a prior incident like this before, I believe, in the US, but usually there's now interlocks and those sort of things that will prevent beaming on if your field size is not correct. So if you are treating for multiple metastases, you can basically treat multiple ones in the same plan. This does introduce some issues where you have some rotational uncertainty as you move further and further from isocenter. Just so I generally recommend having all of your lesions be within 6 centimeters of your isocenter to kind of minimize this uncertainty as you move further from the center of your field. By default, you can place your ISO center at the geometric center of a group. And then again, you would select your grouping based off of lesions that are similar position that you're able to treat with a as small as a field size as possible, and targets that are kind of distinct from other groups that you're treating. The other thing that you could run into is with collimating angle selection. Typically, you can use the standard ones in that table I showed earlier, but in some cases and some target arrangements, like the one shown here, you can have collimated angles that basically require you to have these large open areas because your MLCs aren't able to collimate between them. And this is something that you definitely would want to avoid. In particular, this is another beam collimator arrangement you'd want to avoid because, again, you have your interleaf leakage in the same direction as your gantry rotation, so you kind of have these strips of leakage for these typically high dose per fraction treatments. So again, by changing the orientation of MLC, you're able to get a slightly more defined collimation for each of these targets as you deliver the treatment. And again, if you do have targets that are drifting more like 4 to 6 cm off target, you may consider adding an additional millimeter or so to your PTV margin to account for that rotational uncertainty in like your collimator, gantry rotation, things like that. One of the other issues of concern is if you're treating multiple targets, especially if you're doing them in the same plan, is having this dose bridging. For the lower doses, like 5 gray, we typically won't worry about this, but once you get to about 50% of the prescription dose, this may start to become an issue. in that case, we'll add in these like tuning bridge structures to kind of cut this 50% isodose line in half between these two targets. Again, we want to minimize the basically the contiguous 50% isodose line that we have in the treatment. Right. So for conformality index, there are quite a few definitions that you can use. Typically, the main difference between these two is if you have the volume of the prescription isodose line on the top or on the bottom. With your NCI also basically accounting for coverage of your target when you're including this. So again, this is the conformality of your prescription isodose line. For a lot of these, at least on our cyberknife planning, we'll aim to be less than 1.5 for these definitions, or greater than this for, again, the inverse of these, of this definition. As you add more and more metastases to your plan, it'll get harder and harder for you to meet this goal. Again, for small targets, it may be difficult, but this is kind of a number to aim for if you're doing, especially like a simple plan with a few number of mets that are regularly shaped. So again, gradient index, this is basically the fall off to the 50% isodose line. So standardly for GI, we're looking for less than 5 for targets that are greater than 1 cc, or less than 8 for targets that are less than 8 for targets that are greater than, less than 5 for greater than 1 cc, less than 8 for less than 1 cc. Again, for the smaller targets, it'll be harder to get as well-defined of a dose fall-off. The other way that has been used to define this is the dose gradient index. This is basically a score from 0 to 100 based off of the estimate of you should be able to get a fall-off from your prescription isodose line to 50% within 3 millimeters. And then as you have a fall-off that is shallower and shallower than that, so a greater than 3 millimeter distance between your 100 and 50% isodose line, it'll gradually come down from 100 to some other value. We don't routinely use this in our clinic, but it is an option for evaluating this metric. So again, for dose constraints, this is the template that we'll typically use at our institution. Most of these are pulled from the Tierman tables that Scott showed, though we do have options here for specifying specific point max doses. Again, if we're treating near one of our organs at risk, or treating near something that's been previously irradiated, and we need to raise or lower these point maxes accordingly. Again, for the majority of brain targets, we typically don't run against exceeding these dose constraints. We typically just need to focus on getting our conformality and gradient indexes to be what we want them to be, and typically these dose constraints will fall in place. But again, these are good for reference, and again, for when you're delivering multiple plans, we want to limit the Kaizen dose significantly less than this per plan. The other thing I should mention when we're doing like a lot of these multi-met plans, if you're treating more than a single plan per patient, we generally prefer to have all the plans created prior to the patient starting treatment so you can review the plan some. Especially if you're treating, say, like 10, 15 brain metastases, it's not difficult for the planner to, do one plan, and then when doing the second plan, decide they want to change around which targets are in which group, and then accidentally basically double plan to a target, or accidentally leave out a target that's meant to be treated and not actually have it included in any of the plans that they will be delivering. So being able to review the plan some prior to that, make sure that you're not missing any targets or double irradiating any targets, or again, exceeding any of these dose constraints is extremely helpful. So again, for interfraction imaging, there's a couple of different options. Again, used for our film image treatments. For Align RT, this is a surface guidance thing. I'll talk about surface guidance a bit more on the next slide. The other options that you can have are, say, onboard KV images, like the exact track system that's shown here. This is, again, similar to the CyberKnife system, where, again, you're taking orthogonal X-rays during treatment to check for any motion. The other recommendation for interfraction imaging is typically we'll want to re-image the patient between different arcs just to verify there hasn't been any motion throughout the treatment, and then again proceed or readjust the patient's position as needed. So for surface guidance, this is typically the basically region of interest that we'd have the system track. We'll typically set our tolerance to 1 millimeter. Depending on how your system is set up, it may automatically interlock your machine, or you may have to manually interlock based on the numbers that are coming off of the system itself. Here we typically have manual interlocking for our surface guidance. One of the arguments that you would want to do for this is as the gantry rotates, it can block the cameras that we use for this surface guidance, meaning that you may get a large amount of noise at certain angles or at certain couch kicks. So again, if you're doing manual gating, the recommendation is typically to pause and realign if you're out of tolerance or over 1 second, assuming you're confident that it is a true offset and not noise caused by, again, some offset of your patient. Oh, sorry, some blocking of the system by your gantry. So for machine quality assurance, there is some additional testing that we'll typically do. One of these is the Winston-Lutz test, again, imaging a BB phantom at a number of different couch, gantry, and collimator angles. This is basically to verify that so use your imaging to set it up, and then verify that the walkout of your mechanical isocenter and the alignment of your radiation isocenter with both your mechanical and your imaging isocenter is in agreement. So the tolerance that we'll use for this is 1 millimeter. So typically we'll do this on the morning of any, basically every morning that we may have a LINAC SRS case, we would do this sort of treatment verification, or this targeting verification. On the CyberKnife, there's an equivalence test called the AQA, Automated Quality Assurance, that is a similar thing, verifying that our targeting accuracy or walkout is within 1 millimeter. Point to note, if you're using SRS cones for your treatment, then you'd want to basically do this test using the cone you'd use for treatment, again, to verify that that cone is latching onto the proper location within your field. The other thing that's important to test is basically your end-to-end testing, verifying that you can accurately deliver on an anthropomorphic phantom. For the CyberKnife system, again, this is part of our monthly QA, again, using film or some other detector system to test the accuracy of your full system. Again, typically with a desired accuracy of 1 millimeter. Let's move on to next question. What is the tolerance of a Winston-Lutz test or equivalent targeting accuracy test on an SRS machine?
Okay, so we have 80% participating and in the poll sharing results. So majority answered C.
Yeah, and that's correct. So 1 millimeter is our tolerance for it. As much as I'd like our machine to be more accurate than that, there are some mechanical limitations. Though typically we can get our targeting accuracy, at least based off of our end-to-end tests, around 0.5 millimeter. as long as it's less than 1 milliliter, that's within tolerance. It looks like we're at time. Natalie, do you want me to
Yeah, you
continue, or do you
can
want?
quickly show it. Yes.
Okay, yeah. So I'll just briefly go through specialty SRS machines. So again, Gamma knife, we use a array of cobalt-60 sources in this hemispherical orientation. Again, the advantage of this is you're painting dose from a large amount of angles at once, meaning you can have a very sharp gradient. The downside of this is you're painting, basically doing sphere painting, so your conformality may not be quite as high as other systems especially for irregular targets. For this system, typically the motion management that you'd use is similar to that interfaction, the surface guidance. You'd have a IRBV placed on the patient's nose and then track that again relative to the mobilization poles on the sides of the patient. Again, gating based on motion, typically about 1 millimeter. The CyberKnife is a 6FFF Linac, again mounted on a robotic arm. Our imaging guidance is limited to 2 orthogonal KV imagers, the advantage being that we can take these images during treatment. And then again, the advantage of having the robotic arm is that we can, again, adapt the targeting of the robot to match where the patient location is detected by the imaging. So again, we have different collimators on the CyberKnife itself, fixed, iris, and an MLC. Typically, we won't use the iris for those smallest field sizes because we don't trust its mechanical reproducibility. So for 7.5, we'll use the fixed collimator. For large targets, we'll use the MLC. And then for the intermediate size targets, we'll use the iris. And again, tracking, you can do skull, which is relevant for this talk. The synchrony system is definitely not relevant for SRS. And more recently is the ZAP machine. This was invented by the same, or helped invented by the same inventor of the CyberKnife. It's a self-shielded 3 MV rather than 6 MV treatment machine. Again, use these rotating arms within this shell that contain both the imager and the Linac itself. Again, it has smaller field sizes, so it's more suited for small targets. The advantage of the shielding is that you can drop this in a standard room rather than having to drop it in a Linac vault. Again, with the issue that you'd also see with the Gamma knife of it being somewhat claustrophobic for your patient. And then just a general comparison between these machines.
Thank you so much, Greg. That was excellent overview. Thank you. I will open the floor for questions. I see one question for Scott from Dr. Burek. Thank you very much for the excellent lecture, Professor Soltys. After prior stereotactic radiosurgery, what is your treatment strategy for recurrent brain mets? Specifically, what criteria led you to offer repeat salvage SRS versus transitioning to hippocampal avoidance whole brain RT with Momentum?
Oh, well, you do, of course, the radiosurgery. There's repeat radiosurgery if they get brand new metastases. So we would often just treat them again with radiosurgery rather than whole brain. I don't use their data for like brain met velocity and calculating things like that. I still largely go by number. So we'll treat up to like 20 new brain metastases. If you do radiosurgery and that local metastasis that you treated with radiosurgery, if that grows back, that's a little bit different question. We have done repeat radiosurgery to the exact same site, so re-irradiation. And actually, our paper was accepted just like 2 weeks ago on that. Instead of a like 1% risk of symptomatic radiation necrosis, it's on the order of 10 to 15% radiation necrosis. So It just depends what the treatment intent is and what to do with that. So sometimes we do repeat radiosurgery, sometimes we resect it with surgery, sometimes we do whole brain or some sort of partial brain with that.
Okay, thank you for that answer. Anybody would like to ask a question? Please turn on your mics, cameras. I have a question about the safety, concerning safety. Obviously, these plants can be very, very complex. There are so many mats, and I heard recently we treated up to 60 mats for one patient, few courses. So it becomes very challenging, as Greg mentioned, maybe treating twice one mat or skipping some mats that are supposed to be treated. How do you keep track of this, and what's your strategy to avoid the failure modes?
Greg, you want to?
Oh yeah, so like within the same course, typically we basically keep a consistent numbering and consistent naming. And it used to be that the planners would maybe like rename the targets based on which group we're sending them into. We no longer do that because that was one of the things that led to the issue. Is we basically in one plan named something target 1 and then renamed a different target to be target 1 in a later plan. So we ended up treating it twice. Or well, planned to treat it twice. We did catch it again when we had the plan sum. And then again, that's where having all the plans up front prior to delivering them and being able to review that plan sum really helps, because then it's fairly easy to tell if you have like one met that's getting 40 gray rather than 20, that there's something that went wrong within your planning.
Okay, thank you so much. Another question I have for Scott. Do you worry about normal brain V10, V12? What's your constraint, especially when you have so many mats that you're treating? Are you exceeding all the limits?
Yeah, I mean, the V12, V14, or whatever, they're similar V data for 3 fractions. I think those are applicable for like a single met.
Right.
You can use that. I sometimes use it, but usually I have an idea what I want to do. Now whether, I don't think those are applicable for like total brain V something. Like if I treat something on the left, on the right, it's just independent risk of radiation necrosis.
Serhiy Brovchuk, would you like to ask a question?
Yes, thank you very much for excellent lecture. I do have a question about margin and uncertainties. So I was wondering that typically in the margin, do you also include any uncertainty you can think of regarding the CT imaging? So basically, as I understand, there are a number of CTs that can do sub-millimeter slicing, but those images are kind of reconstructed. And typically, if you do 1 millimeter slicing, it still seems like should be also in a margin for PTV or no, if you can expand on that.
Yes, I think for us, even with the 1 millimeter slice CT, we're still have seen a 1 millimeter PTV margin has been sufficient for us to catch that uncertainty.
So no additional margin
So no
for
additional
volume
margin.
averaging. Okay. Okay. Thank you.
Thank you
But
very
you
much.
would, let's say if you have questionable fusion, would you add margin?
We haven't. Scott, maybe you can comment on that.
Yeah, say you have a bad scan or like motion degraded.
Motion.
Just I usually just draw it sort of loosely or kind of auto draw rather than like draw something
Adding a
fuzzy
margin.
and then add a margin. So
Got it. Okay. Nadia Honcharenko, would you like to ask a question?
Hello, thank you for excellent talk. I have a question about what if we have a higher amount of metastases, like 3 or 5 or higher? what do you prefer to treat them in one fraction or maybe separate treatments, like because usually it's hard to treat a lot of metastasis for treatment to be not so long, like an hour or something. What is your
Strategy.
strategy for this case?
Yeah, part of it is like social, like how far do they live from the center and is it easy or hard to get here? But yeah, I agree. Like if the treatment's much longer, like our treatments are usually not over an hour. So we may do 2 plans over 2 days to treat, 10 brain metastases. Now there are data for like VMAT single isocenter treating 10 mets in, 5 minutes, just a couple of VMAT arcs. And so it can be done. But I think, yeah, you're right. It's time of treatment is the main consideration.
We have found, especially on like CK, once you get it, at least I have less experience on like Linac SRS planning, but for CyberKnife, once you get above 6 mets in a single plan, it's hard to have, you start kind of having to compromise a bit on plan quality in order to keep your treatment time under an hour.
Okay, thank you so much for these answers.
Thank
So
you.
I will share with you the homework that the Stanford team prepared for you. So this is the case that was treated on Linac. Typically, most of our patients are treated on CyberKnife, but this is the case that has 14 mats, and it was treated with 3 plans. So you could see the grouping. The case is called Brain SRS Lecture 6. So if you double click on this, you could see the CT scan, I summed the dose for all of these structures. Okay, and then so there are 3 separate plans. There's also a MR scan, and you could see the scorecard for the coverage, and there are 3 groups of PTVs. This case was treated again on Linac with some margin from GTV to PTV. And so you could see the constraints were met for all the critical organs. I did not put the V10 or V12 constraint here. So I didn't know what you wanted to keep it under, but that's, maybe you can comment, Scott, on this case. I'll scroll through.
Yeah, I don't I don't have a total brain V10. I guess what's a database answer? So I think this is safe to do. I guess you can use the current energy trial. So if the total intracranial volume is less than, check me on this. I believe it's less than 30 cc's, then sure, like any V something should be safe. I think the bigger problem is the bridging when like on that right side, if you have 3 or 4 mets right on top of each other, then
Close.
that's where you get radiation necrosis if there's too much localized V12, V14s.
Sounds good. So you will see the notes for this case entered here. That was prepared by Dr. Soltys and Dr. Szalkowski. So there are 14 mats, so it's quite a complicated plan, but you can download this set and then try to practice contouring. So there's assignment for you to contour all the targets and also OARs, and you can also plan it on your treatment planning stations and compare your plan with a Stanford plan. Stop sharing. If there are no other questions, thank you so much. Thank you, Scott. Thank you, Greg, for such an excellent lecture. That was really educational, and we learned a lot. See you everyone next week. So will be a lecture on prostate SBRT from UCSF team. Bye everyone. Have a good day.